Good morning, guys. Today's video is a comparison between testosterone cypionate, which I consider to be gold standard, and Sustanon, which I consider to be bog standard. Sustanon is an inferior choice of TRT. Why? Because testosterone is testosterone. It's to do with the esters. Now, if you understand pharmacokinetics and pharmacodynamics, you will understand that you ideally want to have one ester because then you can control it. Sustanon is a blend of 4 esters. The only 2 esters that have any relevance are the prop ester and the decanoate ester. Now, the prop ester is a short-acting ester. The decanoate ester is a long-acting ester. When you think about side effects, you want to be able to effectively manage side effects. How do you manage side effects? Normally, dose adjustment. You should already be on the ideal injection protocol. But when it comes to managing your ratio of testosterone to estrogen, it gets a little bit more complicated. So, having a single ester makes perfect sense. You've only got one variable. When you consider Sustanon, it is notorious for causing estrogen spikes. And that is because of the prop ester. Everybody knows that prop is not a suitable choice for TRT. It is the choice of ester for athletes because the washout period is quick. So before they have to have their blood tests, it's normally out of the system. But you actually want testosterone to be bound to an ester. TRT is an artificial state, and what we are trying to do is create as close as natural physiology. And the way that we can achieve that is through testosterone attached to an ester. Testosterone has a short half-life, meaning it'll be metabolized very quickly. From a doctor's perspective, you want to create stable levels. So it's impractical, obviously, to consider using a testosterone that's unbound because it'll be metabolized too quickly, and it would mean that you'd have to apply it constantly in order to achieve stable levels. So you actually want it to be bound to an ester. Testosterone cypionate is that perfect ester. It's not perfect for everybody, obviously. Who's it not perfect for? Guys with super low SHBGs. The majority of guys with super low SHBGs can be controlled with cypionate, but I do have a couple of guys that we've actually had to use on decanate, which has a super long ester, and they're super stable with microdosing. One's on 125 every week and one's on 250 every 2 weeks. But why do you want an ester attached to the testosterone molecule? Well, it has to go to the liver, and it takes time for those carbon atoms to be metabolized and broken down. We don't want spikes. We don't want peaks and troughs. We're trying to avoid that. So once it's broken down, it then gets attached to SHBG, or it can be used as testosterone, can be converted to DHT via 5-alpha reductase, or converted to estrogen via the aromatase enzyme, which is located in numerous tissues. So the ester actually makes sense because you want to have stable levels. That is the premise behind TRT. Stable levels, but having a quantitative level that relieves the negative symptoms that you presented with. That's literally what it's all about. Hormones act on a daily basis, so there's diurnal variation. So traditionally, we've always measured levels in a trough. We don't want to have peaks and troughs. So the most effective way of doing that is having a testosterone attached to a medium chain ester and understanding pharmacokinetics and pharmacodynamics. With testosterone cypionate, you can get away with less frequent injections. However, the qualitative benefits of daily injections and the decreased number of side effects that we have through daily injections makes it the gold standard. So we are mimicking natural physiology. So we see less aromatization to estrogen, less rises in HCT, the lipid profile stays nice and stable. It is the most effective way of achieving stable levels. Sustanon. Oh dear. The only reason to prescribe Sustanon is because it's cheap. So if you get it from a UK chemist, it's cheap. And if you get it from a private practice stroke provider, they will make a big markup on it. And they will tell you that they are super happy. They've tried them all. They've tried every combination, permutation, and 125 of Sustanon every 5 days is the way to go. But always speak to the doctor. No. When it comes to Sustanon, you have to take account of the prop ester, and the only effective way of delivering Sustanon is via the intramuscular route, because it has a high benzoyl alcohol content, and that is an irritant. So testosterone cypionate can be injected via the subcutaneous route. It's less painful and it causes less aromatization of testosterone to estrogen. So if you think about your pinning for 40, 50 years, you don't want it to be painful and you don't want it to cause side effects. So sub-Q is the way forwards. Sustanon is not appropriate to be using that sub-Q. That will cause irritation and potentially an abscess, and then you're in trouble. So Sustanon is notorious for post-injection pain, irrespective of the delivery method. So intramuscular injections of Sustanon cause post-injection pain in a large number of people. The prop ester. Again, let's go deeper into the prop ester, because we've already said that prop's not a suitable choice of testosterone replacement therapy. Well, why is that? Because of the super short half-life, because of the way it's metabolized, and then the effect it has on SHBG. Now, we know that over-aggressive protocols cause a deterioration or decrease in SHBG, and the role of SHBG has been discussed before, and I'll put a link to the blog that Joseph did about it, because SHBG essentially acts as a buffer, because the half-life of these hormones is short, and you need to use testosterone, DHT, and estrogen 24/7, but in different proportions, because there are periods where you're supposed to be predominantly anabolic, and there are periods where you're supposed to be predominantly catabolic. So when we measure in a trough, we react to the numbers, and we say, okay, your numbers are still low, so let's increase the dose. And all you're really doing is exaggerating the peak, which is going to exaggerate your symptoms. Prop is notorious for causing estrogen spikes, and we don't want estrogen spikes. We want a normal amount of aromatization, and so prop is not a good choice. It's the truth. So what else? Well, there's also the carrier oil. Cypionate in Europe, the carrier oil is olive oil. So one could argue it's heart healthy, 1 every 5 a day. It's very well tolerated, which again makes it suitable for both subcutaneous injections and intramuscular injections. The carrier oil in Sustanon is peanut oil. So patients should always be counselled and make sure that they do not have a peanut allergy. Because peanut allergies can be quite serious. They can cause anaphylaxis. So make sure that they have shown due diligence and asked all the correct questions. So, what else can we say? Test sip, gold standard. Sustanon, bog standard.